The human body has an incredible ability to adapt and change to environmental conditions and how we interact in our environment. The cardiovascular system is no exception to this rule. So we're going to look at the cardiovascular responses and adaptations to exercise. We're going to review the heart as a pump. We'll look at anatomy, vascular systems, the cardiac cycle. We'll look at how we control cardiac output and especially blood flow through the working muscle and changes to blood pressure. We'll review basic electrocardiography. Most importantly, we're going to look at the responses to varying types of exercise. So dynamic exercise, which is essentially cardiovascular type of exercise, versus static exercise, which is weight training. Once we have a solid foundation in these understandings, then we can talk about the adaptations to physical activity as well as inactivity. And throughout the lecture, we'll take into consideration special situations as well as pathologies of the cardiovascular system. As with most lectures, we need to understand basic terminology before we can move through the lecture. Stroke volume, or SV for short, is the amount of blood that's ejected from the heart per beat in milliliters. Cardiac output, also represented here as Q with a dot above it, is heart rate times stroke volume. Systole is the phase of the heart where the heart is contracting. Diastole is the phase of the heart where the heart is relaxing and filling with blood. End diastolic volume, or EDV, is the amount of blood in the heart at the end of diastole. So this is the volume of blood that the heart was able to fill with at the end of diastole. End systolic volume, or ESV, is the amount of blood left in the heart after the heart has completely contracted. So even under maximal conditions, we still have a little bit of blood left in the heart. This is the end systolic volume. The central venous pool is the blood that is located in the great veins of the thorax and right atrium. The peripheral venous pool refers to the blood that is in the veins of systemic organs. Total peripheral resistance, or TPR, is the resistance to blood flow in the systemic side of circulation, minus the lungs. Ejection fraction refers to the amount of blood that is ejected out of the heart relative to how much blood filled the heart. So in other words, the stroke volume divided by the end diastolic volume. Blood pressure is cardiac output, or Q, times TPR, or total peripheral resistance. Systolic blood pressure refers to the pressures that are generated from the work of the heart ejecting blood out of the heart. Diastolic blood pressure refers to the pressure that is in systemic circulation when the heart is relaxing or filling with blood. We also refer to this as total peripheral resistance. So when you measure diastolic blood pressure, it's an indirect measure of TPR. Pulse pressure refers to the peak systolic blood pressure minus the diastolic blood pressure in the aorta. This is an indicator of stroke volume. MAP stands for mean arterial pressure. The equation is cardiac output on a per minute basis times total peripheral resistance, or we can also view it as diastolic blood pressure plus 1/3 of the systolic blood pressure minus the diastolic blood pressure. The sinoatrial node, or the SA node, is the pacemaker of the cells in the right atrium. The autonomic nervous system is very important. We have the sympathetic nervous system, or the SNS, which increases heart rate and the force of contraction, as well as the parasympathetic nervous system, or the PNS, which returns the cardiovascular system back down to resting levels. Pulmonary circulation contains arteries, capillaries, and veins. This is the right side of circulation, the right side of the heart. Systemic circulation also contains arteries, capillaries, and veins, but this refers to the left circulation, or the left side of the heart. Let's begin by discussing cardiac output. In order to accomplish exercise successfully, we have to increase blood flow to the working muscle. And this diagram essentially shows you how we do that. On the y-axis is blood flow in liters per minute, and on the x-axis we have 4 different conditions. We have a resting condition with a dashed line that represents the rest through the other bars. There's mitral stenosis. This is where the mitral valve is narrowed, so there's less blood flow being able to go through the mitral valve. We have a normally active person, and then we have an athlete. The different colors represent all of the organs that you see here. The one that we're most interested in during exercise really is muscle. So that's in red. So at rest, only about 20% of blood flow is going to muscle. Someone who has mitral stenosis will only send about 50% of their cardiac output to working muscle, whereas somebody who's normally active can send 75% of cardiac output. But what I really want to impress upon you is that with conditionally, an athlete can send 90% of cardiac output to working muscle. It's important to note that this is maximal exercise. So when you compare a normally active person to an athlete, it's amazing how much more cardiac output because of adaptations of the cardiovascular system that we can send to the working muscle. So how do we accomplish redistributing this blood flow to where it needs to go? We're going to spend the next few slides laying down the foundation for how this is accomplished. But I want you to come away thinking just how amazing the human body is to be able to adapt and adjust to exercise so that we can deliver more blood flow to the working muscle. So let's look at cardiac output another way. At rest, as I mentioned, about 20% of blood flow goes to the resting muscle. Cardiac output in general is about 4.5 to 5 liters per minute. If we use a can of soda as our reference point, so this is a 12-ounce soda, that represents about 13 to 14 cans a minute. So even at rest, we've got a serious amount of blood flow going through circulation. Remember, at maximal exercise, up to 90% of blood flow is going to working muscle in an athlete. With bed rest, cardiac output actually increases 15 to 16 liters per minute. That's about 42 to 45 cans of soda. Why would cardiac output be greater in a supine position? It's a good question, right? If you're thinking gravity, then you'd be correct. Gravity pushes down on blood and forces it to go laterally. But because veins contain one-way valves, blood is pushed back to the heart. So in a supine position, you're going to have greater cardiac output because there's more blood going back to the heart. A normally active individual will have a cardiac output of about 20 to 22 liters per minute, or about 56 to 62 cans of soda. A conditioned athlete has a cardiac output of 28 to 30 liters per minute, representing about 79 to 85 cans of soda. An elite athlete, so we're talking about Olympians here, 40 plus liters per minute of cardiac output. That's incredible, absolutely phenomenal. That's about 113 cans in a single minute. It's always important to look at the anatomy of the heart and to understand several structures. We're not going to cover all of these, but I would encourage you to take a look at all of the different structures. I want to point out a few things here. It's important to note that when we're looking at the heart, we're going to be looking at it as if it exists in the human body. So in other words, the left side of your screen is actually the right side. The right side of your screen is the left side. So systemic circulation is the left side of the heart. Pulmonary circulation is the right side of the heart. To drive this point across, you as the viewer see my right side as your left side. You see my left side as your right side. So when we look at anatomy, we're always looking at it from the perspective of how it exists in the human body. So the right side of my heart is what you see as the left side. The left side of my heart is what you see as your right side. It's important to look at the myocardium from the perspective of the thickness of the muscle. On the right side of the heart, the muscle is very thin, versus the left side of the heart, the muscle is very thick. Why would there be a difference in the thickness of muscle in myocardium between the right and left sides? It all comes down to the pressures being placed on the heart. The right side of the heart is a very low pressure system. The left side of the heart is a high pressure system. So that's point number one that I want you to come away with from this anatomical view of the heart. The second thing is that we do have valves that are important here. We have the tricuspid valve that's on the right side of the heart, and we have the mitral valve on the left side of the heart. We're going to be talking a little bit more about these valves, especially the mitral valve, so you want to get familiar with where these things are located. The mitral valve allows blood to come in from the left atrium into the left ventricle of the heart. The tricuspid valve is important because that is the valve that allows blood to come in from the atrium of the right side of the heart into the right ventricle of the right side of the heart. Two other important valves here as well that are worthwhile mentioning: the pulmonary semilunar valve, which allows blood to go out from the right side of the heart out to the lungs. On the left side of the heart, we have the aortic semilunar valve, which allows blood to go from the left ventricle out to systemic circulation. One last point to come away with is that the inferior vena cava and the superior vena cava are both bringing blood from that central venous pool back to the right atrium so that we can recirculate the blood, pump it out to the lungs, and then pump it back to the heart, and then pump it out to systemic circulation with oxygenated blood. The heart is essentially a pump that is located in a closed loop. We have the heart, we have large arteries, feed arteries, and then arterioles, and eventually capillaries. That's the left side of circulation, or the systemic circulation. Moving on from the capillaries into pulmonary circulation, we have the venules, small veins and large veins. These progressively get larger so that we can collect more and more of that deoxygenated blood and bring it back to the heart into the right atrium. There are various pressures that are placed on the heart. Let's first look at afterload. Afterload represents the forces that the heart has to contend with in systemic circulation in order to eject blood from the heart. Whereas preload is the pressure, for lack of a better word, that is placed on the heart as a result of blood returning back to the heart. This pressure is a low pressure and is more about the volume of blood that's returning back to the heart as opposed to the pressures in pulmonary circulation. So with afterload, we're looking at systemic circulation and the forces that are placed upon the heart to eject blood out of the heart. And preload represents the volume overload placed on the heart, which, as we'll see, places a stretch on the heart that the heart has to contend with. So preload refers to the ventricular filling pressure of the heart. Remember, that's that volume overload that's coming back into the heart. That's affected by three main components, which we'll look at a little bit more closely: the skeletal muscle pump, venoconstriction or venous constriction, and respiratory movements, or simply breathing. Afterload refers to resistance of blood flow from the heart in systemic circulation. This is where static and heavy resistance exercise, as well as hypertension, tends to have its greatest effect, is on afterload, whereas dynamic exercise really has a large effect on the preload of the heart. Continuing on with anatomy, we have to have a way to supply the heart with blood flow. We do that using the coronary arteries. And so these two figures are showing you the anterior and posterior view of the heart and the blood vessels, the major blood vessels that supply the heart with a blood supply. There are two major blood vessels that supply the heart with the blood flow: the right coronary artery and the left coronary artery. The left coronary artery branches off into the circumflex branch, which feeds the posterior myocardium. It's also important to note that the left coronary artery branches off into the left anterior descending branch. This is what we call the widowmaker, because most of the blockages that occur with a heart attack are occurring in this branch. So when does the heart get its blood supply? Is it during systole or diastole? If you said diastole, you'd be correct. The right and left coronary arteries originate just after the aortic valve and in that ascending portion of the aortic arch. So what happens is that during diastole, as pressures in systemic circulation subside, blood falls back into the left and right branches of the coronary arteries, and that's when the heart's going to receive its nutrients, its blood supply. It's important to note that blood vessel dilation within the heart, as in many other blood vessels, is linked to the metabolic activity of the heart. So if the activity is higher, it's going to get more and more of a blood supply to respond to the higher demand for oxygen. In coronary artery disease, what happens is that we get plaque accumulation. So it's a blockage that can occur. You have narrowed blood vessels, which reduces the amount of blood flow to anything downstream from that blockage. So if we reduce blood flow, then that means the heart is going to receive fewer nutrients, fewer oxygen molecules, and therefore we can't keep up with the increased demands. As an example, what you'll see in the snowiest parts of the country, that first snowstorm is where you tend to see a very high increase in the number of heart attacks that occur. Now, why is that? Well, that's because, as we'll talk about a little bit later, but doing any kind of shoveling really places a much higher demand on the vascular system, which increases the forces that the heart has to contend with in order to get blood out of the heart. So if we increase the metabolic demand for oxygen in the heart, but yet we have this obstruction with plaque, then there isn't going to be an appropriate response as far as an increase in blood flow to that myocardial area. So what ends up happening is that that part of the heart begins to necrose or die. So that will cause angina or angina, you can pronounce it either way, which is pain associated from the fact that the metabolic activity is increasing, yet the demand for that blood flow has not been met with an equal supply of blood and therefore oxygen. In just 1 to 1.5 minutes of hypoxia or a lack of oxygen supply, the heart begins to die. There's damage that occurs, we get necrosis. That necrosis is what we call a heart attack. So you get a myocardial infarction. This is in contrast to a skeletal muscle, which you can cut blood flow off for hours and get very little damage to that skeletal muscle. This just highlights the fact that the heart is very oxidative. Now, the different layers of the heart are perfused differently and have different oxygen demands. The epicardial layer tends to be more rich in a blood supply, so a blockage there is less significant than the endocardial layer. The endocardial layer is where a myocardial infarction or a heart attack is most likely to occur. An important piece of the puzzle into understanding why this happens is the isovolumetric phase. During this phase, there is no blood movement out of the heart, but yet there's a lot of pressure that's developed. The heart is essentially performing an isometric contraction. Just remember, when does the heart receive its blood supply? That's during diastole. If we're contracting, then we have to be in systole. So if we prolong this isometric contraction in order to build up enough pressure to eject blood from the heart will be ischemic for a longer period of time. So in other words, if I have, let's say, high blood pressure, so my TPR or total peripheral resistance is high, there's going to be a certain amount of pressure in the system that the heart has to overcome in order to push blood out of the heart. So during this isovolumetric phase, what the heart is doing is building up enough pressure in order to be able to overcome TPR and push blood out into the bloodstream. So people with high blood pressure are putting an extra load on their heart because their heart is spending more time in the isovolumetric phase, which means that the heart is going to be ischemic for much longer. I'm going to use a water bottle to explain afterload and how the forces of afterload affect somebody with coronary artery disease. The green cap represents the aortic valve. The pressure that's keeping that aortic valve shut is what we refer to as total peripheral resistance. During systole, what happens? We have a phase called the isovolumetric contraction phase. That's when the heart is contracting, so I'm squeezing this water bottle, and hopefully no water goes flying everywhere here. But I'm squeezing this water bottle, creating a lot of force, a lot of pressure. That pressure now within this bottle is much higher. That aortic valve still hasn't popped open. I have to, in order to eject this water or blood out of the heart, have to increase the pressure in the bottle to the point where this lid pops off. Same thing with the aortic valve. The aortic valve has to pop open when there's enough pressure in the left ventricle that's higher than what's out in systemic circulation. If I increase the pressure to the point where it's greater than systemic circulation, the aortic valve pops open and blood goes rushing out of the left ventricle. Somebody with coronary artery disease will spend a lot longer time in the isovolumetric phase, so this isometric contraction. There's a high likelihood that if someone has blockages in the coronary arteries, they also have blockages in the periphery, which means that TPR is going to be higher. If total peripheral resistance is higher, that means this person's heart is going to spend a much longer time performing that isometric contraction, so squeezing that water bottle, Therefore, the isovolumetric phase is prolonged, which means that the heart is going to be ischemic for a longer period of time. That sets the person up for a heart attack. So a person who doesn't know that they have coronary artery disease suddenly goes out and shovels snow, a very high intense activity, can set themselves up very, very quickly for a heart attack because of these mechanisms. This is a classic diagram of the cardiac cycle. It has 4 sections. The top section shows you the timing of the ECG or the EKG. That's the electrical activity of the heart, which we'll talk about later. We also have the heart sounds in orange represented there and when those occur. The second section looks at pressure. So that y-axis there has pressure from 0 to 110 millimeters of mercury. And we look at aortic pressure, left atrial pressure, and left ventricular pressure. The third section of this graph has left ventricular volume from 0 to 130 milliliters. The last section of the graph shows you the timing of when everything occurs. So from diastole to systole to diastole again, and when valves are opening and closing, and when there is filling and ejection in the heart. The first point I'd like to make is in reference to the left ventricular pressure. That's the line in red. As you can see, that pressure increases significantly during systole, especially during that isovolumetric contraction phase that we just talked about, peaks and then comes down very, very quickly, and then we have diastole where pressures are very low. This makes sense. In order to eject blood from the heart, we have to overcome total peripheral resistance. So we have to increase the pressure in the left ventricle and continue to do so to overcome the pressure in systemic circulation known as TPR. During diastole, those pressures are very low because the heart is trying to fill with blood. The second point I'd like to make is that of left ventricular volume in the third panel of this figure. As you can see in diastole, we have an increase in the volume of blood that fills the heart. During systole, just past the isovolumetric ventricular contraction phase of the heart, you can see that the blood empties very, very rapidly from the left ventricle. And during diastole, the heart fills with blood once again. It's important to note the time of the cardiac cycle on the x-axis at the top of the screen. Please note that it is less than 1 second where all of these events are occurring. That's pretty impressive. So the next 2 slides are simply a summary of everything that is depicted in that graph that we were just looking at. The main point that I want you to come away with during diastole is that this is the phase of the heart where we are filling the heart with blood. And a lot of the blood return to the right atria really is passive. It just basically falls into the right atrium. So there isn't a lot of pressure needed to return blood back to the heart. During systole, we have high vascular forces, and this is mainly going to be confined to systemic circulation or the left side of the heart. That's why, if you recall, the left myocardium of the ventricle is thicker than the right side because this is a pressure system. And once again, I want you to come away with thinking about this isovolumetric ventricular contraction phase and how that relates to people with coronary artery disease and just how dangerous it can be if we introduce high vascular forces in the circulation when they have this disease. The second point I want you to come away with is that in order to get the aortic valve to open so that we can eject blood from the left ventricle and out in the circulation, we've got to build up enough intraventricular pressure in the left ventricle in order to overcome TPR. This graph is a little bit more advanced, but does give us the ability to visually see the relationship between intraventricular pressure and intraventricular volume. So on the y-axis, we have intraventricular pressure in millimeters of mercury, so that's looking at the pressure inside the left ventricle. And on the x-axis, we have intraventricular volume in milliliters, that's looking at the volume inside the left ventricle. There are actually 2 graphs within this one graph. You can ignore the center graph for now. That won't make as much sense until we get to the muscle structure and function chapter. So I would encourage you to come back and revisit this diagram after we've talked about those concepts. So let's start on the x-axis here at 60 milliliters of volume and look at diastolic filling. In order to accomplish diastolic filling, you can see that intraventricular pressure does not increase very much. Blood just fills the left ventricle. The point at which the heart stops filling with blood, that volume that remains in the left ventricle, that's what we call the end diastolic volume. So in this example, we're stopping at 130 milliliters. So we've filled the heart with an additional 70 milliliters of blood. In order to eject that blood from the heart, we're going to begin to build up pressure. So that's now where we see a rise in intraventricular pressure. This is the isovolumetric contraction phase that we talked about earlier. As the left ventricle continues to contract, it continues to build pressure. But since we've already exceeded the pressure of TPR, we are now able to eject blood out of the heart. So our intraventricular volume begins to decrease as we move to the left side of the diagram. Once contraction ends, that volume that's left in the heart is what we refer to as end systolic volume. In this example, we're saying that the volume left inside the heart is 60 milliliters. During diastole, we have isovolumetric relaxation. So you can see that the intraventricular pressure now decreases back down to almost near zero so that we can start the process all over again. How is this graph going to be affected by someone with an increase in hypertension? Remember, hypertension increases TPR, which increases the afterload or the workload of the heart. Let's evaluate this. If somebody has hypertension, that means they have a higher TPR, so the total peripheral resistance is higher. That means I'm going to spend a lot longer time in this isovolumetric contraction phase, which means I'm going to have to build up more left ventricular pressure, so that intraventricular pressure is going to increase. So the point where the aortic valve was opening in someone who is normotensive now increases to a higher level. So let's say instead of being at 90 millimeters of mercury where the aortic valve opens, it may now open at 100 millimeters of mercury. This shifts the ejection curve higher. So now you'll build up even more pressure to squeeze out blood. It's important to note that during the isovolumetric contraction phase, we are shortening the sarcomeres, we're shortening the muscle. When we continue to shorten the muscle to build up pressure, that means we're using more and more sarcomeres. That also means that I have fewer sarcomeres and fewer shortening distance to get blood out of the heart. So what's going to happen? The end systolic volume is actually going to increase. So instead of being able to get 70 milliliters of blood out of the heart, maybe you'd only be able to get 50 milliliters out of the heart, which means there's more blood left in the heart because you can't squeeze that blood out because you spent so much time in the isovolumetric contraction phase building up pressure to overcome that high TPR. So instead of being at the point where intraventricular volume is 60 milliliters down at the bottom of the graph, we might be 2 tick marks over at 80 milliliters of intraventricular volume. How does this graph change if someone increases preload? So during cardiovascular training, I get an increase in the amount of volume that I can return back to the heart. What's this graph going to look like then? If I increase preload, let's say I'm starting at the 60 milliliters again, and during diastole, because preload is greater, my end diastolic volume is going to be greater. So this filling phase is going to shift this line over to the right. So my end diastolic volume is going to be greater. So instead of 130, let's say it might be 140 milliliters. I'm still going to go through the isovolumetric contraction phase, and if I somehow manage to lower TPR, I might get the aortic valve to open at, let's say, 70 millimeters of mercury, which means I can spend more time squeezing blood out of the heart, which means that my end systolic volume more than likely is going to be lower. That just means that I've squeezed more blood out of the heart. So maybe my end systolic volume now is at 50 milliliters. So what about increasing the forcefulness of contractions? Is that going to change the graph any? If I can increase the forcefulness of the contraction, I'm going to affect the pressure in the left ventricle quite a bit. If I increase the forcefulness of the isovolumetric contraction phase during systole, I'm going to be able to open the aortic valve sooner and, of course, eject more blood out of the heart. So that means that my graph is going to shift to the left in terms of the intraventricular volume or the end systolic volume. I'm actually going to decrease the end systolic volume, which is a good thing because that means that I've ejected more blood out of the heart. So hopefully you can appreciate this graph and how it's useful to be able to visualize the relationship between left ventricular pressure and left ventricular volume. I would encourage you to draw these out on your own and map out the changes that occur with preload and afterload, as well as forcefulness of contractions. That's going to be really useful into deepening your understanding of how afterload and preload affect the heart. The table off to the right-hand side of the screen just gives you some numbers to put some context behind this graph and what you might see with someone who's got a normally functioning heart versus somebody who's got systolic dysfunction or somebody who has diastolic dysfunction. And by the way, you can have both systolic and diastolic dysfunction at the same time, which means that you're going to have some serious cardiac issues. The big question you should ask yourself at this point is, how does the cardiovascular system deliver that cardiac output to the working muscle? How is that regulated? We're going to look at 4 different areas. We'll look at mechanisms that are intrinsic to the heart. We'll look at muscle afferents, as well as neural regulation, as well as peripheral regulation. When we talk about mechanisms intrinsic to the heart, we're really talking about the Frank-Starling law. This essentially says that if we can increase preload, so we increase the stretch being placed on the heart, that is going to force the heart to have a responsive elastic recoil that increases stroke volume. So picture it like a rubber band being stretched and then snapping back into its resting shape. If we stretch the heart with a bunch of blood, then that heart is going to respond by snapping back down and squeezing more blood out of the heart. That results in an increase in stroke volume. It also causes the heart rate to increase. So we're getting 2 things happening here. We stretch the right atrial wall because we've increased preload. So remember, that's a volume overload. We're stretching the heart more, filling the heart more with blood. And that causes an increase in not only the stroke volume because of the elastic recoil of the heart, but it also increases heart rate. 2 things that increase cardiac output. As far as muscle afferents are concerned, we have mechanoreceptors and chemoreceptors. Mechanoreceptors are stretch receptors. They respond to movement essentially. They're located throughout the human body. We have joint kinesthetic receptors, which are located in joints. We have some in the lung that you don't see pictured here. We have the muscle spindles, which we'll talk about later on in the course, as well as the Golgi tendon organs, which again we'll talk about later in the course. There are skin receptors as well that are responsive during exercise. These all provide input to the central nervous system in order to make adjustments that will fine-tune exercise. The chemoreceptors are also important because they provide input as to what's going on chemically and metabolically to the central nervous system in order for the central nervous system to make fine-tuning adjustments to the new homeostatic demand being placed on the body during exercise. As far as neural regulation is concerned, we can look at the cerebral motor cortex, also known as central command, that responds to several different triggers. We have the anticipation of exercise, so knowing while you're at the starting block, let's say if you're a sprinter, you're going to be exercising, you're going to be sprinting very, very fast. That anticipation can cause some changes, mainly an increase in heart rate. We have the muscle mechanoreceptors that are also triggering the central motor cortex to respond to exercise. So remember, these are the stretch receptors. As we move, we are stretching these receptors and they're firing and sending signals to the central nervous system. We also have those chemoreceptors that are telling the central nervous system about what's going on chemically. This is all providing input to central command. The cardiovascular control center response, which is located in the medulla oblongata, is going to basically increase sympathetic nervous system output and decrease parasympathetic output. Increased sympathetic output is going to result in increasing heart rate. That anticipation that we talked about earlier, anticipating exercise, that alone will increase heart rate. The sympathetic nervous system can increase heart rate in a healthy young person from 200 to 250 beats per minute. That's astounding. That's just from sympathetic output. This is called a positive chronotropic effect. Basically, anything that's chronotropic affects heart rate. We also get an increase in SA node discharge. The SA node, remember, is the pacemaker of the heart. So we're going to increase the amount of electrical activity that comes out of that SA node, as well as improving the conduction velocity within the heart's electrical system. This is called a positive dromotropic effect, which affects the conduction speed. So anytime you change the conduction speed, you're talking about the dromotropic effect. Increased sympathetic output also increases the force of the ventricular contraction. This is a positive inotropic effect. In other words, we change the force that's produced. Now, it's important to note here that this doesn't change the rate of force development. So the speed at which we can develop force doesn't change. In order to do that, you have to change the enzyme availability and change the enzymatic rate in order to change the rate of force development. In the graph on the right-hand side, you can see the effect that sympathetic stimulation has. On the y-axis, there's stroke volume. On the x-axis is the ventricular end diastolic volume, or the EDV. Under normal resting conditions, or our control here, that's the orange line, as we increase the end diastolic volume, the stroke volume increases. But if we add sympathetic stimulation simply from more forceful contraction of the heart, then I can increase the stroke volume just from that SNS input. Sympathetic nervous system output also increases the release of epinephrine from the adrenal gland. And as you recall from metabolism, that serves two important functions. Do you remember what those functions are? 1, to increase glycogenolysis, and 2, to increase lipolysis. Increased sympathetic output also generally increases vasoconstriction across both systemic and pulmonary circulation. If we're talking about pulmonary circulation, we are talking about an increase in preload. So by venoconstricting the veins, we can actually increase the amount of preload that we get, which means if I can return more blood to the heart, I can take advantage of that Frank-Starling law. I can place greater stretch on the heart, which means I'm going to get more recoil response from the heart in terms of squeezing more blood out of the heart. It's important to note that venoconstriction refers to vasoconstriction of veins. It's important to understand that we are not cutting off blood flow when we perform venoconstriction. If this was the case, we wouldn't have an increase in preload. I'm going to exaggerate this, but let's say we went from a blood vessel that was this large down to a vessel that was this large. So we didn't cut off blood flow. All we did was reduce the size of the vessel to promote more blood going back to the heart, thus the increase in preload. SNS output is also going to increase in skeletal muscle. Of course, if we want to move, we've got to contract muscle. That requires SNS input. But we have something called the skeletal muscle pump. This is where muscles are squeezing and bearing down on the veins, but because there are one-way valves, that blood is pushed only in one direction, and that is back to the heart. So two things here so far are increasing preload. We've got venoconstriction and the skeletal muscle pump. As we are exercising, muscles are contracting, that's squeezing down on veins, that's pushing blood back up to the heart because veins contain one-way valves, so we're pushing blood only in one direction, back to the heart. That increases preload. SNS output, generally speaking, causes vasoconstriction broadly across the cardiovascular system. That's going to increase preload for us by two mechanisms so far, venoconstriction as well as the skeletal muscle pump. But we can add also the respiratory pump. During exercise, what are we doing a lot of? We're breathing in and out. Our breathing is accelerated. This changes the pressure differences within the thorax. Rhythmic deep breathing that is controlled by the cerebral motor cortex, and we'll learn more about that later on once we get to the pulmonary section, causes changes within the thorax as far as pressure changes. We go from an area of higher pressure to lower pressure. This pressure gradient changes with deep rhythmic breathing. If we reduce pressure within the thorax, that means that more blood can return back to the heart. That increases preload. So there are three things here that are really important to us as far as increasing preload during exercise: venoconstriction, the skeletal muscle pump, and the respiratory pump. These are all things that are happening during exercise that serve to increase preload so we can take advantage of the Frank-Starling law of the heart, that is, placing a greater stretch on the heart, volume overloading the heart. What type of exercise increases this? Cardiovascular type of work. So running, swimming, walking, gardening. We also need to talk about the periphery and how that's regulated. In general, as I mentioned, the sympathetic nervous system will constrict blood vessels with just a few exceptions. The main question I want you to ask yourself here is if the sympathetic nervous system is in general causing vasoconstriction, particularly in systemic circulation, that means that we would cut off blood flow. How are we diverting blood to the skeletal muscle that's working and that has a very, very high demand for a blood supply? The answer is that we're only going to increase blood flow to active working areas. So there has to be something that allows vasodilation in the working muscle so that we can supply blood to that skeletal muscle. This increased blood flow through contracting muscle fibers is going to closely mimic the pattern of motor unit recruitment. Let's take a look at this redistribution of blood flow. On the y-axis, we have the change as a percent from resting value. On the x-axis, we have various organ systems. What do you see here? All organ systems, except for the spinal cord, have a reduced blood flow. Why did this happen? Because of the increase in SNS activity. Remember, that causes, in general, vasoconstriction. The spinal cord, however, since that is heavily involved in regulating how we're responding to exercise, is going to have an increase in blood flow. That makes sense. We're delivering more blood to the spinal cord so that it can effectively regulate exercise. So how does the redistribution of blood flow work? In what I'm calling the vascular tree, we have these large arteries that have few sympathetic nerves, so that means they have less SNS input. They respond more to stretch. So if you stretch them more by pumping more blood through them, they'll respond with recoil and push blood along the vascular tree. Then we have the smaller arteries and arterioles, which are richly innervated and do respond to the SNS. These arterioles are the gatekeepers of blood flow. They're going to provide the largest resistance to blood flow and have the greatest amount in pressure drop. How does this all work? Well, the contracting muscle fiber releases adenosine. Do you remember adenosine? This is from adenosine triphosphate, or ATP. We're also going to have an increase in potassium ions as well as hydrogen ions that are coming from lactate. That changes the pH. To some extent, inorganic phosphate is also going to be a vasodilator here. We also have ATP-sensitive potassium channels. These channels are very responsive to unperfused tissue. When there's a drop in ATP, these ATP-dependent potassium channels are going to open up. That opening the potassium channel causes hyperpolarization. This hyperpolarization then is going to close off calcium channels, which then is going to allow the cytosolic free calcium to decrease. That then results in blood vessels dilating. This, therefore, increases blood flow. Now, I realize that we haven't talked about calcium's role in muscle contractions, but when we do, what I'd like you to do is come back and revisit this section because then it'll make a lot more sense. But essentially, calcium is needed as the mineral to cause the cascade of events that facilitate muscle contraction. So if we can remove the amount of calcium around, then we're going to reduce the amount of contraction. In this case, we're going to have vasodilation because the blood vessel walls are more relaxed. And lastly, we have something called reactive hyperemia in response to mechanical compression. Anytime you bear down, so skeletal muscles are bearing down on these blood vessels, that's going to cause some changes in the pressure of oxygen and carbon dioxide. So you'll have a lower amount of oxygen and a little bit more carbon dioxide. That causes blood vessels to react to that situation and increase blood flow. So the main point off this slide is that we have these arterioles that are responding to locally produced metabolites that result in vasodilation. So what ends up happening is that these local metabolites then block SNS input. So the vasoconstriction that we're getting in general that causes the redistribution of blood flow, so diverting it away from organ systems that don't need a lot of blood at the moment because we have this demand for oxygen to the working muscle, all of those signals are blocked in skeletal muscle. So these vasodilator signals are propagated up the vascular tree. The small arterioles are going to dilate in response to these substances from these actively working muscle fibers and cause a redistribution in red blood cells, aka blood. That vasodilator signal is then going to be propagated up the vascular tree, eventually to the feed arteries, which don't have a lot of SNS input. The feed arteries will increase blood flow into the working muscle in direct proportion to the amount of vasodilation experienced by the arterioles. All of this vasodilation by the arterioles reduces the afterload. And as you recall, the afterload is important because that's going to determine how long the heart spends in the isovolumetric contraction phase. The goal during exercise is to reduce that isovolumetric contraction phase so we can get more blood out of the heart and push it to where it needs to go. That is the working skeletal muscle. So in other words, this arteriolar vasodilation decreases total peripheral resistance, or TPR. That decreases the overall amount of work that the heart has to perform. So let's summarize everything we've talked about thus far. We've talked about cardiac output during exercise. How do we deliver that cardiac output to the working muscle? A big part of the changes in cardiac output come from central command, or the cerebral motor cortex. We have an increase in the sympathetic nervous system, or the SNS. That's going to increase heart rate, stroke volume, as well as, in general, vasoconstrict blood vessels. We talked about the importance of preload and how can we increase preload. There are 3 ways to increase preload: through venoconstriction via the SNS, the skeletal muscle pump, as well as the respiratory pump. We talked about how do we redistribute those red blood cells through the working muscle. We have arterial vasodilation, which causes a redistribution of blood flow, as well as a drop in total peripheral resistance that causes a decrease in afterload and the amount of work that the heart has to perform. I want to take a moment just to make sure that you keep some aspects of what we just talked about straight. Remember that when we talk about afterload, we're talking about the left side of the heart. We're talking about TPR. That's it. So all we're talking about are the changes in total peripheral resistance and how that affects afterload. If we move over to the right side of the heart, we're talking about preload. And there are 3 things that affect preload: the venoconstriction, the skeletal muscle pump, and respiratory movements. It's important that you keep that preload separate from the afterload, which only deals with TPR. So if I asked you a question that talked about the skeletal muscle pump and how that might affect afterload, in your mind you should say those 2 don't connect with each other, because they don't. The skeletal muscle pump only refers to changes in preload. The only thing that's going to affect afterload is the TPR. This slide is where we get to put it all together. So at the bottom of the screen, we've got our cardiac output. We're trying to increase cardiac output. We're going to use exercise as our model, which you see at the top of the screen. So what happens during exercise? We know we get an increase in heart rate. We multiply that by stroke volume. We get cardiac output. Those are the 2 components. So heart rate and stroke volume both increase. How does that happen? Well, central command tells the parasympathetic nervous system to relax. So we cut back on the parasympathetic nervous system. That allows heart rate to increase more. The SNS is going to be stimulated, which we talked about increases the amount of heart rate that we can get. We also increase stroke volume by increasing the conduction velocity as well as the force of contraction. The SNS in general is going to cause vasoconstriction, which that causes venoconstriction, which then affects preload. If we increase preload through venoconstriction, we're going to increase the stroke volume and therefore the cardiac output. We also have contracting skeletal muscle. We know this to be the skeletal muscle pump. So during exercise, the skeletal muscle pump increases preload, which again increases cardiac output. We're also breathing during exercise. We're breathing more, we're breathing deeper and more rhythmically. This also increases preload because we change or lower the pressure within the thorax to allow easier return of blood flow back to the heart. That increases cardiac output. Vasoconstriction also increases total peripheral resistance. However, during exercise, we know that an increase in TPR increases afterload. That would reduce our stroke volume. However, during exercise, we have local responses within contracting skeletal muscle that allow arterioles to respond to the metabolites being produced so that we get vasodilation, which serves to basically decrease TPR because we've vasodilated so much more. That serves to reduce afterload, which means we increase stroke volume and therefore increase cardiac output. So the next time you go for a walk, think about these mechanisms. Think about how is blood flow increased to the working muscle? How is your cardiovascular system, how is your heart going to respond to the changes in dynamic work that you're performing?